I'm Brad Power, and this is, according to my count, this is the 11th weekly update on Linnea's hackathon. And today, there's a fair amount for Linnea to report, but there may not be a lot to discuss. So we'll see if there are things we want to talk about. I never fail to be amazed that we can, find things to talk about. But Linnea, why don't you give us an update?
Sure. Well, since I saw you last, I've had a biopsy and I started the clinical trial. And Brad may or may not have relayed that last week was just a tsunami of a week in other respects, with things just going on in my life that frankly I don't have time for, but I have to deal with. So I've been just trying to hold it all together. However, I can happily report that they got sufficient material, 4 different plugs and 2 cc's of fluid. And thus far, I believe there is tissue going to Caris and to, I think, proteomics. But Jesslyn paid very much attention to your advice as far as prioritization, and after reviewing things, agreed that if we were to send to foundation too, there could be some redundancy. So I talked to David, and he was very gracious and said that they are there at any point in the future should they be needed. So nice to know. And as far as the trial, thus far it's been pretty easy. I'm still dealing with the pain of my cancer, and I vomited a couple of times, but in the world of clinical trials and cancer treatment, that's no big deal. So yeah, hopeful.
I see that Brian Tomlinson is on representing Foundation, so we'll send our thanks to Foundation through Brian.
Thank you, Brian.
Yep, as David said, Linnea, we're here if you need us. Just reach out to one of us.
So grateful. Thank you.
So Caris and mProbe, and then I guess, how long do we know? Do we know how long till we get those results back? Is it a matter of a few weeks, something on that order?
That's not a question I have the answer to right now. I'm not sure if Jesslyn does either.
Kimmery or Allie, do you happen to know how long these, or maybe Brian, how long do these tests typically take when the tissue, from time tissue is shipped off till Linnea has a report back?
I mean, I can't speak for the other companies. From the time that Foundation Medicine receives a tissue sample, it's less than 2 weeks typically.
Great. That'll set our expectations. And thank you.
So was it sent to Foundation? I missed that part. Was part of the sample sent?
I think it was, and then Jess asked them not to use it. I'm not quite sure on the train of events, but I know that MGH works closely with Foundation, so that one may have happened very quickly. But in the meantime, there is additional tissue, which is pretty huge to come out of a biopsy with that.
That's really good. Can you ask if they may, I think if they can send it to Foundation, or if they already did, it would be really good to know, just to set expectations that in a few weeks we may have some, more like precision oncology approaches to add to whatever else is on the table to consider for treatment.
Yeah,
I know Kimmery's on a call right now, but
I just finished. Sorry, my cousin's having breast cancer surgery at the moment, and her surgeon just called me. So sorry.
Oh, I'm sorry.
Yeah,
sorry.
No, it's good. It's early stage. We caught it early, so it's all good. So
good. Kimmery, we're talking about the Foundation versus Caris.
Mm-hmm.
And after reviewing with Jess, she she agreed that there was some overlap there.
Yeah, yeah.
So at this point, there is tissue not going to foundation, but rather going to Caris. There is some excess tissue, which is a good place to be sitting. So,
Right, right. And Linnea, did the clinical trial that you're on ask for any tissue?
there was a biopsy required at the beginning, but I have a feeling that the standard path report that comes back essentially saying, I have adenocarcinoma, that's probably sufficient for them, but I'm not certain.
Yeah. So I keep asking that question because
No, it's a good question.
if it's not a requirement for your, like to put it in the terminal, if it's not a protocol violation for you to not give tissue, and it's just a request rather than an inclusion criterion, which probably isn't since you're on it, then I wouldn't necessarily give. I mean, I would just ask very carefully what they want the tissue for if they are asking or requesting for any.
Right.
It's likely not going to benefit you.
No. Last week was an eye-opening week in another way, in so much as I had conversations with both Jess and Alice about two upcoming trials that I was excited about. And one is for TPX, a 4th generation ALK inhibitor. And the other is a therapy using TIL through Iovance. And they both sounded super intriguing, like they'd be appropriate for me. They'll be at MGH in the fall, but neither one will admit me because of preclusions, because I've had 3 or more therapies. So my platform has broadened here, where I just find this appalling that they would lock out those of us who come this far on this journey and who are so in need of these potential therapies. Part of what Alice suggested was that there should be a compassionate use leg in trials, that does not necessarily need to report back data, but just to address this need.
There may be, Linnea, a way for her to request compassionate use directly to the company. I mean, there are reasons why they exclude heavily pretreated patients, because it stacks the odds against having a positive clinical trial readout. But usually, if there's a compelling, and if your physician is willing to go that extra mile and ask for compassion, it's like a named patient protocol is what it's called sometimes as well. There might be, that may be more difficult for the TIL one, but for the ALK inhibitor one, I would think that she would have very good credibility in approaching a company for compassionate use.
Yeah, I think she was excited about the TIL therapy and frankly didn't understand why they'd have that preclusion, because it's a basket trial and it's phase 1. But
Peggy, you wanted to say something?
Yeah, I wanted to reference a biopsy that, Linnea, that you'd had, if I understood properly, in an earlier trial. And you thought maybe they just used that to get the pathology. If you were to read the trial or ask the PI, they could probably tell you if there were additional correlative studies that took that tissue and examined it that you just wouldn't even be necessarily aware of. And I would pursue that. And if nothing else, that biopsy at that time with the responses that, or the expressions or whatever they'd be looking for, may be relevant to what's happened in the journey along the way.
I would think so, but this is the biopsy that opened my eyes to the difference between clinical and research, because I just flat out asked, when am I going to get results back from this? And was told there would be no results, that not even the principal investigator would see. It was just going back to the sponsor.
Yep. That's how it, that's why I'm strongly advising you not to give a requested and not a required tissue sample in any trial moving forward.
Yeah, and that this one, there was the option to do an additional one, and I was like, no way.
Yeah.
So,
Because it really is for their own internal research use purposes.
yep.
I just want to comment that for unique situations like yours to get, there are ways around the FDA that I've heard about that XCures is a specialist at. So we have friends at CancerCom as XCures, and you can essentially get an N of 1 clinical trial. There's a bunch of paperwork that's required, but and so you have to have a physician who's willing to sponsor you and willing to go through hours of bureaucracy, but it can almost always be done to get access.
Yeah, that's the named patient protocol that I was mentioning, Brad. Yeah.
Okay. So there's, if it comes to that point, that we can lean on friends to help you through that, to get access. Allie had a couple of comments here. You want to give voice to those, Allie?
I'm just saying that it would be good to get some reassurance that the foundation report was indeed ordered and the sample was sent.
Yeah, I'm sure that it's not happening just because I've spoken to Jess and David, but I can double back on that.
Can you just ask? It doesn't hurt to ask, because I don't think that it's redundant with Caris and the proteomic type of reporting. It's more complementary than redundant.
Well, one of the things that Kimmery suggested was doing them sequentially, again, being very sensitive at all times to using tissue. And so maybe we could look to get the Caris results and then see if the foundation report additional information would be complementary.
Well, Linnea, as far as I know, the foundation medicine testing was not ordered.
Okay.
I can circle back
That's
around.
my
with David, but-
understanding too. Yeah.
So just let me or David know if there's anything you need. We are
Thank you.
100% here for you.
I'm so grateful. Thank you. And when David called, it felt a little bit like we were breaking up. I was sad.
To that point, I mean, are you still planning to you could still do a liquid biopsy through foundation? And that might be more
That's what we did
complementary.
initially, right?
Yeah.
Yep.
So I do think there is overlap between Caris and foundation. I mean, I think that's the case, but it would be interesting to do a liquid biopsy alongside a tissue-based biopsy to get that kind of triangulation as well.
Linnea, I think you already had Foundation 1 liquid CDX testing done.
I do. Yep.
But how long ago is the date on that relative to the recent, your unfortunately your last results indicated pretty, more recent aggressiveness. And I just wonder if the blood sample taken before is truly representative of what's going on with the biology right now.
Yeah, I'm not sure.
I guess, I would do as many of those as anyone's willing to do for you.
I agree, completely agree. I mean, the ALK that needs to be addressed, nobody is refuting that, but it's different when some cell, progression, proliferation is driven by ALK and let's say KRAS versus ALK and CDKN2A or P53. And a lot of these, passenger alterations, they come in and they take over for some time and they drive or co-drive actually with some of the alterations that were the root cause. And staying true to the biology of the situation is really important once you decide the next steps in treatment. That's why we want to be, I think, most comprehensive about catching all of the perspectives, genomics, proteomics, but at least knowing the DNA-based drivers, it's really revealing. And there could be, off-the-shelf approved drugs that in combination could be pursued, and some doctors may be willing to acquire those drugs in different pathways for you. So we want to be able to make sure at least we consider it for decision support of the final clinical care team decisions. So I think that the time is probably now to get the latest. And since you said that you had a different picture now in your situation, it probably, well, biologically changed, because if there's no biology change, there would not be a change in symptoms and the assessment that you got recently. So we want to be true to the biology and assess it right now.
Right.
I'm going to end the formal portion now. And